Another rule, I'll tell you that in a second. So we're not going to be talking about Obamacare in any way whatsoever. It has nothing to do with people going into or on Medicare. There are some small minor provisions in the law that will affect you. I'll touch on those, but the overall Patient Protection Act, really nothing to do with you guys. Everybody's situation is unique. Even though Medicare system is a federal program, covers all Medicare beneficiaries, everybody's situation within that system is generally unique. So again, as we go through, I'm prohibited by answering specific questions about specific individuals in an environment like this. So you write it down, I'll answer your question because I know it's unique to you. CMS, that's Medicare, it prohibits me from requiring you to provide contact information. However, if you provide it so that I can contact you to answer your question, I will do so. But I don't want you to think when you leave here today, if we don't call you because you didn't give us permission, we didn't want to give you the answer. There's a lot of rules in CMS, and one of the most important rules is I can't call you. You have to ask me to call you. Follow that? So that's a very important rule. You always have to follow that. Here's some more rules we need to know about. First and foremost, this is considered a formal event, not an educational event. Why? Formal events, I can discuss specific products. Educational events, I cannot. So I want you to be aware you're in a formal sales event. I'm going to talk about specific products to help you understand the overall general environment you're going to be operating in. As I said before, normally we give out books, but we can't. We're prohibited by law. I can't discuss any products unrelated to Medicare and Medicare Advantage programs. So we're going to be very specific. So even though Don Conrad's Capital is sponsoring your event, they're a wealth management firm, they talk about life insurance and investments and all that stuff, none of that can be discussed in this open forum. If you need to talk about those subject matters, you have to write it down. They'll be happy to call you and talk to you about how your pension affects your Medicare, or how Social Security is affected by distributions. All that kind of stuff, I can't talk about it in this environment. I can't answer any questions about health conditions. It's considered cherry picking. So if you have a health condition that's specific to you and you want to know how Medicare is affected by it, write it down. We'll answer it privately. And most importantly, I'm going to be using very specific language given to me by the law, such as, you probably see it on TV all the time, no plan premium, zero plan premium. It means you don't pay anything for it. It's free to you. But I can't say it's free to you. I have to use very specific language like zero plan premium. So when I use a phrase or a language and you say that doesn't really make a lot of sense, it's the way the law requires me to say it. So again, if you have a question about that, write it down. Lots of rules, right? I have more than 30 years underwriting experience. I put a little information. Our organization, however, is staffed by a lot of different types of people, CFPs, LUTCFs, RHUs. We have a lot of background in a lot of different areas. The most important thing about me today that you need to know is I'm 30 years Medicare underwriter. I started one of the biggest medical insurance companies in the country. They have a little show about animals on TV. I can't name them specifically. I'll sing the jingle though if you like. No? So I have a lot of experience and background, over 30 years in the Medicare business. I'm going to try to bring that to the fold here so that we're all aware of what's going on. This is the flow of the seminar today. First, we're going to review some important changes that I picked out in the law. There's lots of things occurring in Medicare that are going to directly affect you. I picked out 3 very specific things because how they affect you will be very interesting to you because it's how you're going to plan for your health care in the future. Second, I'm going to discuss how you enter the Medicare system if you're turning 65. Third, I'm going to discuss some risk solutions, which is another word for insurance programs. And fourth, I'll address any question you have at that point if time permits. So you need a pen so you can write your questions down. The scope of appointment, which I gave you. Scope of appointment is this form right here that everybody should have. Yeah, you don't have one? Okay. Neither one of you? Okay. This is a very, I'm sorry. This is a very important form. Here's why. Under federal law, I can't talk to you unless you authorize me in writing. This is the way the government has it all set up.
Does everybody have a pen? Does anybody need a pen? Okay.
So I can tell you all this information, but if you say, what about this? I can't have a discussion with you unless you sign something in writing. It's the way the law works. So you have to sign the scope of appointment, and that allows me to tell you whatever you want on a conversational basis. Other than that, I can just transfer the information to you, and that's going to be it, okay? This is a federal rule that I have to follow. I will not violate it because I'll lose my license, okay? So you need a pen. You need the scope to sign and the booklet to follow along. And here we go. You ready? We're done with all the questions and the answers. Okay. First, you are now in what's called an annual enrollment. The annual enrollment is when any Medicare beneficiary can change their health plan. It starts on October 15th and it will cease on December 7th or end. If you don't make a change or take some action about your health care, if you're not satisfied with what you have now, if you don't make a change, you will go into what's called lock-in. And January 1st, that'll be the end of it. You'll be, whatever you have then is what you'll have for the remainder of that following year. So annual enrollment, which is what we're in right now, is the time to make a change. If you don't do it by December 7th, you're locked into whatever you have for the remainder of next year, until the next annual enrollment. So I'm going to try to give you a lot of information to help you make a decision if you're planning on making a change, to kind of expose you to what's in the environment, and that way you can make an informed decision about how you're going to handle things. Okay, here's the first thing that I think you should know about. Again, there's hundreds of events occurring in Medicare. I only picked out 3 because these are very specific things. First, there's a thing called sustainable growth rate. This is how Medicare determines every year how they're going to manage the cost or the inflation in medical care and how it's delivered to you. In essence, what the sustainable growth rate is, it says if medical care goes up 10% one year and 22% next year, and the federal government decided that they should be only going up 3% per year, every year following an increase, they will reduce what they pay physicians in the following year. So as an example, if you went to see Dr. Smith and he got $100 last year for his office visit, and the feds, Medicare themselves, said it should only go 3% up to $103 this year, but it went up 110% to $110, they will reduce what he pays him in the following year 7%. So in other words, if things are going faster than the federal government says they should be going, they will just simply reduce what they pay physicians year over year over year. Because of this thing, the sustainable growth rate, which no one's ever heard of, it's part of the law though, this year, coming in 2014, all physicians are going to get about 15.2% less than they got in 2013. So in other words, your doctor's going to be paid less for the same service next year. How does that affect you? It's a very slow, insidious thing that is occurring here, because what's happening is your physician's reimbursement rate for how he's getting paid is creeping down. So he's a businessman. He's got to make a decision on how he's going to stay in business. What's he going to do? He's going to simply transfer your delivery of medical care to lower cost medical technicians. And that's why today, when you go into your physician's office, you generally don't see your physician right out of the gate. You see a nurse practitioner, a phlebotomist, some kind of low-end medical technician who can work for less because he's making less. He's going to have to get more volume into his practice at lower cost, and he does that through transference of medical care. The second thing that occurred this year in 2013, and will roll over into 2014, is Medicaid reimbursement. Now, if you're on Medicare, it really has nothing to do with you. Medicaid is not Medicare. It's a program for the impoverished. But prior to this rule, if you went into a physician's office, often you'd see a sign that says, "I don't treat Medicaid patients." The reason for that is very simple. It's economics. If your doctor got $100 to treat you as a Medicare patient, he would get $10 to treat you as a Medicaid patient. There was a huge discrepancy in the reimbursement rate for physicians to treat Medicare and Medicaid. So what happened is, in 2013, Kathleen Sebelius, the Secretary of Health and Human Services, passed a law and enacted an executive order that says if a Medicaid patient pays 10 and a Medicare patient is paid 100, we, the federal government, will step in and make up the difference of $90. So now for your physician, there's no difference between Medicare and Medicaid as far as what he gets paid. How does that affect you? It affects you dramatically. There's 50 million people in the Medicare system. There's 50 million people in the Medicaid system. All those Medicaid patients just became same as reimbursed as you as a Medicare beneficiary. So now your physician has a lot more patients to treat because he's getting paid the same. This is an overall plan, because when they get Medicare and Medicaid to come up par as far as reimbursement goes, it's just a matter of time before they merge the two systems. Now physicians are treating Medicare, Medicaid, it doesn't matter to them, they're getting paid the same. So this act, along with the sustainable growth rate, is a dramatic effect on how healthcare delivery will be delivered to you. Because your doctor's a businessman, needs to make money, but he's getting paid less this year and will continue to be paid less year over year. He's got more patients to treat. He's going to become the Henry Ford of healthcare, the assembly line type of healthcare system. That's what it's really going to transform to, and it's going to take time. It won't happen like that, maybe 5 years, 6 years. The way the government moves, if you look at the history from 1909 all the way up to 2014, it's very little nibbles at a time. They never come in at one big time and take a big bite. Nibble here, nibble there. It's slow and insidious. You maybe notice it, maybe you don't, but it will affect how healthcare is going to be delivered to you. So that's why you see now physicians are going to what's concierge physicians. You ever see those guys now? They're saying, hey, don't worry, I'm bailing out of Medicare. You'll pay me a monthly fee. I'll be at your beck and call, and I'll only treat maybe 500 patients in my overall practice. So physicians are trying to get away from the Medicare system by saying, hey, I don't want anything to do with it. But the reality is the bulk of a physician's practice is Medicare patients. The likelihood of them surviving in the overall market is very low unless they have a very unique clientele base. So these two events right here are going to dramatically affect how healthcare is going to be delivered to you in 2014 and beyond. You need to be aware of it. This is an overall, what's the word? This is telegraphing to you how healthcare companies are going to deal with it. This particular article, which came out of the New York Post on October 26th, is, in my world, tells me everything I need to know. Here, United Healthcare, one of the largest healthcare providers in the entire country, just canceled their contracts with over 2,000 medical providers in Nassau and Suffolk and the boroughs. Why did they do that? Because normally, United Healthcare is a healthcare company, and they're in the business of acquiring large pools of people. They go out and say, buy our plan, become part of our network. When you become part of that network, what they do is they turn their attention, with you behind them, to what's called an IPA, an Independent Physician Association, which is a group of doctors who contracts with United Healthcare to deliver services. But United Healthcare says, when you contract with us, we're not going to pay retail. We pay wholesale. And what occurs is something called repricing. If that doctor normally got $100 from Medicare, United Healthcare says, I have 100,000 members, which will all point to you. You don't have to build a practice. We have the patient base, but we're only going to pay you 70 cents on the dollar. So they're working at a discount. They're called repricing the services. So that physician group makes a decision. We don't have to build a practice. They have 100,000 members that have to be using us. They're forced to use us through the network. As a result, we'll increase the volume in our practice. We'll work for less. We'll transfer healthcare to lower-cost medical technicians. You see where it's all going? The whole trend in healthcare is managed care. But United Healthcare is only under a mandate in the Medicare environment to provide so many doctors in a certain geographic region. Not every doctor has to be available to you. Only so many cardiologists, so many oncologists, so many radiologists in an area based on the population density. So they made a very big decision here. They essentially said, we don't need 2,000 doctors in the area. They're all out of the network. So that means everybody who joins that plan can no longer see their physician because that physician is no longer part of the plan by contract. You follow? So now, how does that affect you? If you had that plan, and you've been seeing that doctor for 5, 6, 7 years, 10 years, whatever, and you want to continue to see that doctor, you'll pay cash out of pocket. That's what we call cost shifting. If you choose to continue to see that doctor who just got thrown out of that plan, they just shifted the cost to you, and you're paying out of pocket. If you want to stay in that plan because it has a co-payment arrangement for you, you have to change your doctor. You have to make another healthcare decision about who, when, and where you'll get your health care. For them, it's a big thing because essentially what it means is they're no longer paying out a monthly stipend to all those physicians to retain them in the network. So this is a cost-cutting measure, which is also a network restriction measure. It's minimizing how many doctors you can see. Very, very important if you're in a healthcare plan. Other plans did it as well. Emblem did it, and all the other what's called managed healthcare plans are cutting their physician rosters, so therefore anybody who remains in that plan has less choice about who they're going to see. So those are the three most important things that I think are going to affect you going into 2014, and why this one's important is if you're choosing a Medicare Advantage plan that has a managed care component, in other words, a network of doctors, and you chose it because your doctor was in it, your doctor may not be in it as of January 2014. You have to be very, very careful in that respect, okay? So, not all is lost. Under the new federal law, Obamacare, if you will, these particular items here, which are all preventative in nature, were installed in the Medicare system. Prior to this, if you went to the doctor for preventative care, it wasn't covered. There was no medical necessity to it. But the law changed, and now the law essentially emphasizes prevention rather than treatment. So, for example, now they want you to go out and get a diabetes screening, a blood test to see if you have high blood sugar. If you have high blood sugar and they can diagnose it early and they can get you to change your diet and lose some weight, you may not become diabetic, lose a limb due to amputation or neuropathy, and have to go on insulin. So the new trend in healthcare is very simple when you put it all together. Early detection and prevention, treatment of healthcare issues before they get out of control, lowering the cost of healthcare by transference to lower cost medical technicians and offices, and high speed or high volume healthcare practices. You put it all together, and what you have is essentially an assembly line type of healthcare system that wants to restrict the access to physicians who work at a discount in the marketplace. See how it all goes? So even though all this is good, meaning they want you to test early and get treatment early, that's a good thing for you. You have to be aware of what the overall picture is. The overall picture is that when you use managed healthcare in the Medicare environment, you're going to go into a restricted network that's going to speed you along rather than spending the time that may be necessary for you. That's a decision you have to make about whether or not you want to go into that system or not. Okay, so now we're going to talk a little bit about the Medicare system in general, if you have no question. Anybody have any questions so far? No? Okay, great. Yeah.
So that's only if you, the choices would be Advantage, managed healthcare, and not.
Correct.
If not, then there's a 20% copay associated with that?
Correct. We're going to address that. It's a good
Okay.
question. Yeah. Did you have a question, sir?
Yeah, you were saying that the doctor that you might have now and use would be out of the network even though you're there. How could you find out if the doctor is going to stay in that network in 2014 when this is implemented?
Yeah, right now during the annual enrollment, any doctor who's going to stay in the plan would be in that plan. So you have to look at their roster of physicians in a geographic area and see if he's still in. But again, physicians could get cut at any time. When you're in Medicare, Medicare only requires the plan to go into effect on January 1 and provide benefits for the 12 months. It's not required to maintain the network of physicians. They can change them at will. The whole issue about managed care is it is a restricted environment that provides a network of doctors that you must use. If they're not in the plan or have that doctor has decided to bail out or the plan has decided to get rid of him, you could be left in the plan and with no access to the physician you want to go to. Very important point.
So, I'm sorry, how did they make the decision what doctors are in?
I don't know the internal workings of those carriers, but if you think about it, it's probably pretty obvious. When a plan contracts with a doctor, they essentially say, listen, we know you can get $100 from Medicare for your office visit. We have 100,000 members that we know have to stay in our network. So if you want to be in our network, we don't want to pay wholesale. I mean, we want to pay wholesale, not retail. So will you work at 70 cents or 60 cents on the dollar, whatever their negotiated fee schedule is? Most likely, that's a deciding factor on what physician stays in and what physician stays out, what they'll work for. But more importantly, the health plan is supposed to provide what's called area access. Area access means if you have a population density, let's call it 1 million, and it's in a county, let's call it Suffolk, Medicare says there has to be 3 cardiologists in that entire district. That's the minimum access. Not necessarily the sufficient amount, but the minimum amount. So that's another deciding factor for the plan. They only want to meet the minimums because they have to pay them a stipend on a monthly basis generally to maintain them in the plan. and they only require so many physicians. So it's a pricing issue, one physician working for more or less. Yes, sir?
Haven't they done this all along anyway?
They've been doing it slowly but surely, yes. You're constantly kind of restricting the networks, constantly doing that. Every now and then you'll hear about a hospital's gonna come out of a plan. That's just a negotiating issue, you know. So it happens all the time with what they call coordinated care or managed care. But this is a very severe event. To dump 2,000 physicians in a local area, that's a significant amount or a significant percentage of providers in an area.
I just got a call from a client this morning, chiropractor, an insurance company said in order for them to stay with the insurance company, they've got to accept 40% less.
Well, there you go. Yeah,
That was just this morning.
yeah. But think about the overall impact. Medicare's cutting 15, and now the plan's saying, of that lower amount, you want another 40. That's what, a 55%? He's working for half.
Correct.
You want your physician to make money. You want him to be profitable. Because if he's not making money and staying profitable, he's not going to be in business. So when you do have a health issue, he's not going to be there, right? I'm a big advocate. Medical providers need to make a decent living. They need to be in business. But at the same time, you need to keep your health care affordable. It's a give and take a little bit. But when they're taking 50% cuts, any physician, he's just a businessman like anybody else, he has to take a move. He has to move some way to stay in business. It's simply shifting the cost down to lower cost technicians. That's how he's going to do it probably. Or move to cheaper rent, I don't know. Yes, sir?
These negotiations are taking place between now and January 1st?
Actually, they usually occur mid-year. They've already probably happened because what happens is a Medicare Advantage plan has to submit what's called a bid to CMS sometime in June. The bid is saying, here's the plan, here's our pricing based on what's called the regional benchmark rate, which I'll explain in a minute, which is the monthly amount they get. And that has to be approved sometime before the open enrollment. So they start around June, July, August, the bid amount is either accepted or declined, the plan decides to stay in the business or not, and then right around October, it opens up for the 2014 season. So a lot of this stuff has already occurred, previously. You're just seeing the impact of it now. Any other questions? Okay, great. All right, so now we're going to go into the Medicare system a little bit. Here's my good friend Albert Einstein. I like him. He's always said, listen, I don't know much about history, I don't know much about biology, and I certainly don't know anything about health insurance. What he's really saying to you is, if you want to know about physics, go to a physicist. If you want to know about insurance, go to an insurance guy. Talking to the mailman about the plan is not going to help you. They're not versed in this area. So you really need to focus your energy when you're making these decisions to deal with people in the industry. It's a complex, ever-evolving industry. And I would encourage you to speak with somebody in the industry. Here's a little trivia for everybody. Do you know who signed the Medicare Act? Nobody?
Johnson.
Johnson, you're actually right. Lyndon B. Johnson signed the Medicare Act in July of 1965. But it wasn't Johnson who brought Medicare to Congress. It was somebody else. You know who? Anybody?
Kennedy.
Close. It was actually Truman, the guy sitting right next to him. Truman brought the bill into Congress, but it took Johnson to sign it. You can see it's a long span of time from bringing it in to getting it enacted. Also, do you know who the first Medicare beneficiary was? Truman. So it pays to be president. You're always first in line. So it was actually Harry Truman who brought the bill to Congress. It was Johnson who signed it. But universal health care, the concept of Medicare, goes way, way back. It goes back all the way to 1909 and Theodore Roosevelt, who was the first president to propose universal health care in the United States. And even he didn't think of it. It was Otto von Bismarck in Germany who enacted the first universal health care law in the world in 1889. So universal health care has been around a long, long time. Medicare is just a shred of the overall concept. Because when Medicare was enacted in 1965, the average lifespan of a U.S. adult male was 66. I'd be almost dead now. But when they enacted universal health care in 1889 in Germany, the lifespan of an adult male in that country went up 14 years. So that's why when they enacted 1965 saying, 1965, that when you retire at 65, you'll get Medicare, the concept was that you probably wouldn't live to see it anyway. So the system was built on a false promise of, hey, everybody gets free health care at 65 through the Medicare system, but they knew at the time you probably wouldn't live to see it. But what they failed to see was the lesson of history, which was that when universal health care gets enacted, lifespans increase. They didn't account for the increase in lifespans, more people coming onto the system, and the aging of the US population. When Medicare was enacted, there was 4 working adults to support 1 retiree. Now, there's 3 working adults to support 1 retiree, and it goes down every year. The Medicare system was broke financially. So that's why in 1997, under the Balanced Budget Act that Bill Clinton signed, they enacted Medicare Plus Choice, which ultimately became what you know and see on television as Medicare Advantage. What is a Medicare Advantage plan? It's a very simple concept. If you're an original Medicare, Part A and B, hospital doctor, and you have a $1 million claim, the federal program has to pay that for you. They're on the hook, and I'm going to explain how that works. Medicare Advantage is nothing more than the transference of the liability that the Medicare system poses to the federal system to a private insurance company for a premium. It's no different than what you do with your home and your auto insurance. So I'm going to show you how that works. But that's the concept that they came up with in 1965. But you can see the long duration of time that it takes to get things enacted. It's the same thing on those first items we were talking about. Sustainable growth rate, transference of cost and all. These are all little nibbles. It takes a long time for the government to act. So, with that said, in 1965, there were 2 parts enacted under government program. Part A, hospitalization. Part B, physician services. The important aspect of these 2 parts here is that when the programs were enacted, they were government-run programs. The government took over your health care and delivered it to you through that system. But in 1997, under the Balanced Budget Act, they signed Medicare Part C, or what you know as Medicare Advantage. When it first came into law, it was called Medicare Plus Choice. Why Medicare Plus Choice? Because Medicare Part A and B is an entitlement. You are entitled to it by law. You paid for it, you get it. Medicare Part C, you're not entitled to it. You have to voluntarily choose to leave Medicare Part A and B and go into a Medicare Advantage plan. That's why they called it Medicare Plus Choice. You made a choice. But that didn't sound so good, so they amended the name to Medicare Advantage later on, because it's what you say, not what it actually is. So when I say, hey, it's a Medicare Advantage, it sounds much better than Medicare and make a choice, right? So here's the important aspect of these 3 things. These were enacted in 65, government-run programs. In 97, the Balanced Budget Act brings Medicare Part C in. Why? Because the Social Security system is financially collapsing, and they're talking about bankruptcy, and what are they going to do, and Medicare's going to go out. So they created this environment, but what they did is they transferred the risk of Medicare to commercial insurance carriers, who now say, we will provide all your Medicare Part A and B services for you, equivalent for a monthly known premium that the government will pay to us, and the government relieves themselves of the liability that you pose. It's the same thing you did with your homeowners. You bought a homeowner's policy. If your house burns down, they give you $1 million or whatever it's worth, right? And you pay a premium, a known loss, a fraction of what the risk is. Medicare Advantage plans is simply that concept being brought to the bear as far as your healthcare delivery system. But things changed, and everybody wanted prescription drug coverage. So in 2003, under the Medicare Modernization Act, they bring prescription drugs to the fold and initiate a plan that says you can get prescription drugs through the Medicare system. But the important thing here is that prescription drugs has nothing to do with a federal program transferring risk. It's a completely privatized health system. All they did is they passed a law and says you get prescription drugs, and they handed it over to commercial insurance carriers to administer and deliver to you. So you can see, as I said before, the transition is slow. 1965, 1997, you go from government to government and commercial insurance, and now you're fully privatized in 2003. It's a fully privatized system overseen by federal program. So the transition is very clear if you look at it over history. They're transitioning away from government-run healthcare to commercially run healthcare systems where the government simply pays a fixed cost for you, a premium every month, and relieves themselves of the liability. But it's government run to commercial run. It's a very important aspect of the way your healthcare system is going. Why? 12% of the entire Medicare population every year transfers its risk from original Medicare to Medicare Advantage plans, 12% a year. That means theoretically, in 5 years, 100% of Medicare beneficiaries will be getting their Medicare benefits from commercial insurance carriers. But on the flip side of it, 72% of those people go back to original Medicare when they joined a managed healthcare system. Why? Because nobody likes to be told you can't see your doctor. You want to see the doctor you want when you want to see them. So people go to Medicare Advantage plans because of some feature that they saw, either pricing or some other advantage that was presented to them, but they realize in a year this is not what it was billed as, and 72% of them go back to original Medicare. So the system is slowly migrating towards commercialized Part C plans, but at a slower rate. So what do you get for your Part A? It's very simple. Part A is everything from the emergency room door in. Hospital room and board, ICU, labs, x-rays, nursing, anything from the ER door in is your Part A. And Part A, this is the cost for it, because health insurance, just like any other insurance, it's a cost factor. Medicare Part A in 2013 had what's called a premium-free premium. In other words, they said it's premium-free. But is Part A premium-free? It is not. When you get your Medicare Part A at age 65, you've prepaid it over your working life, because you had to have 40 quarters or 10 years of work paying FICA taxes to fund the premium for your Part A. You just simply get it at 65. They call it premium-free. I like to say it's premium-deferred. You paid for it all along. And the risk that's presented under your Part A is very simple. You went to the hospital. The minute the doctor says you're being admitted, you're on the hook for $1,184. That's your deductible. But if you stay in there more than 60 days, you have to pay $296 a day along with Medicare. And if you're in there more than 90 days, it's $592 a day along with Medicare. These are co-payments. So if you have an extended hospitalization over a protracted period of time, you're exposed to roughly $45,000 of risk under Medicare Part A. So even though Medicare Part A is good, it's not complete coverage. And you do have risk from the moment you go in. The other aspect of Part A is very simple. This deductible is not a calendar year. It is a per cause. You go into the hospital today, you incur that deductible. If you exit the hospital more than 60 days and re-enter, you incur that deductible again. It's what we call a claims-made deductible, not calendar year. So theoretically, you could actually incur that deductible multiple times in a year if you have multiple entries into the hospital. Okay, Part B, we know it as physician services. It covers ambulance, blood, diagnostics, ER, PT, and now it covers preventative services, as I told you before. What's not covered under Part B is the things that a lot of people look for, which is vision, hearing, and dental, and chiropractic. Part B does not cover those, not a covered service. But everything from the emergency room door out, including your office visit, that's a Part B service. What does this cover you for? What does this cost? In 2013, the cost for your Medicare Part B, which you have to voluntarily choose, not automatic, you have to choose to get it, it's $104.90. I rounded a little bit. So if you have Medicare Part B, for sure, without exception, you'll be paying about $1,200 a year in premium out of your check or directly to Social Security, however they're going to do it. You have a $147 deductible, but your coinsurance, what you pay along with Medicare on a claim, is 20% unlimited liability. So if you had $1 million claim under Medicare Part B, you could have a $200,000 liability. You owe 20% of it. That's why the Part B exposure prompts people to make a decision about getting what's called secondary or wraparound coverage. They want to cover this 20%, because if you had a $1 million claim, you don't want to pay $200,000. You'd rather pay a premium, a known loss, to avoid it. So your exposure under Part B, it's unlimited. That's the important aspect to know. Unlimited liability under Medicare Part B. Okay. If you're entering the Medicare system, you're turning 65, this is an important thing to know. there are 3 times that you can enter into the Medicare system. The first one is what's called the initial enrollment period. This is very important. If you are turning 65, you have the month of your birth, the 3 months prior to that, and the 3 months after that. In other words, it's a 7-month window in which you can enroll in your Medicare Part B and get on the plan. So if you were born on June 2nd, you have March, April, May, the month of June, July, August, September to enroll in Part B and get onto Part B. If you miss that, or have missed it, you have to move. This is how it looks graphically. See, 3 months before, the month of, and 3 months after. If you miss your IEP, you have to wait for what's called the general enrollment. This would be a bad thing. Here's why. Let's say that you were born in April of April 2nd of 1948, as an example. You had January, February, March, April, May, June, July to enroll in Medicare. You miss it. Now you have to wait till January. You're not covered for August, September, October, November, December. In January, you would enroll in the general enrollment now, and your coverage would not be effective until July 1st of that following year. You could potentially go a whole year without coverage, roughly. So when you coming up to your initial enrollment period, it's very important that you execute on it. If you're over 65 and still working, and on a group employer plan, you have a waiver on that. You get what's called a special enrollment. When you come off your group plan, you can enroll and go into Medicare at any age within that 7-month window. But here's the important thing about this. If you're 68 years old, you take retirement out of your employer and you're on their group plan, so you come off the group plan and you choose COBRA, and you stay on COBRA for 18 months and then want to go into your initial enrollment, you don't have it. COBRA does not allow you an initial enrollment. You waited 3 months past your eligibility date, you disqualified yourself, and now you got to wait for the general enrollment. So by taking COBRA over 65 and going through the Medicare system, you could potentially expose yourself to a long period of no insurance. Very important to understand how these periods work. Okay, now we're going to talk a little bit about the prescription drug aspects of the system. This is what I kind of visualize the prescription drug questions that I get. It's very, very confusing, prescription Part D plans. Why? It's privatized. Insurance companies decide how to present them to you. There's a federal guideline for the plan, but insurance companies want to make themselves different, distinguish themselves among the pack. So they come up with various designs on this drug plans to attract you, if you will. But this is really, let's skip over this. This is the federal design for prescription drug plans. No matter what you see in the marketplace, this is what it actually is. You have a $310 calendar year deductible. So when you buy a prescription drug plan, generally it's going to impose a deductible from January 1st forward. You pay the first $310. After that, the plan will pay 75% of the cost of the drug, and you pay 25% of the cost of the drug. But this is not what is presented to you. What is presented to you is when you go to get a generic drug, it's $5. Brand name is $20. Non-preferred brand name is $45. Why do they do that? Because if they said, listen, you pay 25% and we'll pay 75%, what would be the next question? 25% of what? Like, what does the drug cost? 25% of 100, 25% of 10? So what they do is they simply mask this with a copayment. They say your copayment is $5 for generic. That's probably the equivalent of 25% of the drug. They just give you a fixed cost because it's palatable to you. That's the whole system, the way they do it. After you reach $2,850 worth of prescription drugs, you go into the infamous donut hole, which you've all heard of, in which you pay 100% of the cost of the drug. But when they enacted the law in 2003 and brought this into the system, they didn't anticipate the back push from the general population of Medicare beneficiaries. So what they did is they now tell you they are closing the gap. What they're actually doing is this. Show you how that works. This is what they're actually doing. In 2014, when they say they're closing the gap, what they're actually doing is they're giving you a discount on the drug. So if you bought a $10 drug in 2014, you only pay $7.20 in real dollars, but they will credit you $10 to get through the gap. It's fiat money is what it is. It costs you 10, but you only pay $7.20. And year over year over year, they keep doing that until 2020, you pay $2.50 for a $10 drug. Well, I don't think that's closing the gap. What I think it really is they're extending the initial coverage limit, aren't they? If it's 75-25, they've just taken this and they've pushed it up, and they phased it in over a 7-year period of time, giving you larger and larger discounts over a period. So when they say they're closing the gap, and I say language is important, we don't call it Medicare Plus Choice, we call it Medicare Advantage. They say they're closing the gap, they're just extending the initial coverage limit. That's really what they're doing there. Once you spend $6,455 in prescription drugs total, the plan goes catastrophic, and you only pay 5% from then on out for generics and brand names combined. They'll tell you it's $3 generic, $6 brand name, but it's just a percentage of the total drug cost. So the drug plans are very confusing when you look at how they're presented. Here's the most important thing you need to know about prescription drugs. Your drug has to be on the formulary. Your drug isn't on the plan's formulary, it's useless to you. It means nothing. Because if you get a $12 drug plan and you have to pay $100 for a drug that's not covered on the formulary, your monthly cost is $113. So it's very, very important that you check the formulary to make sure your drugs are on, because the plan is irrelevant. Even though you want to be with a good company, company name means nothing. It's the formulary, because they're all regulated by the federal system, all right? So check the formulary. It's very easy to check the formulary. You go to Medicare.gov, you plug them in right there, and it tells you every plan that covers every drug you take. Of course, no one can predict the future, right? So we don't know what drugs you might have to take in the future, so it's very important that you kind of get a good plan, but at the same time, you don't want to buy a plan that's more expensive than you need. Do not forego your prescription drug plan. Here's why. If you're eligible on January 1st of any year and you don't take a drug plan, so let's say you go 10 years without a drug plan, and then one day your doctor says, hey, you got to start taking a medication. You join a drug plan. Because you were eligible for those 10 years and chose not to, the Fed system imposes a 1% penalty per month permanently when you enroll. So if you went 10 years, it'd be 120% on top of the normal premium. That means a $40 drug plan will cost you $80. In other words, you can't avoid paying. You're going to pay at some point. The only question is, will you pay now or pay later? The penalty is severe and permanent. Do not forego your drug plan. If you don't have drug usage, the cheapest one in the marketplace just to avoid the penalty. It's very simple. Okay. If you make more than these amounts, 85K, 107s, 160, and 214, in addition to the monthly plan premium, you will pay an additional premium based on your income. It's what they call an IRA. So if you're making, let's say, $86,000 a year in total income and you're single, and your normal drug plan premium is $40, you'll pay $51.60 because they impose an additional $11 premium on top of you. There's also lots of different programs. See that one there, pharmacy assistant direct programs? Every drug manufactured everywhere has a pharmacy assistance program. That's where the drug manufacturer sets up a foundation that sets up some rules to see if you can get the drugs at little to no cost. So if you're taking Humira as an example and you meet Humira's foundation's qualifications, you could potentially get those medications at no cost to you. So it's very important to know about your drug plans. So now we're going to talk about Medicare Part C, which is Medicare Advantage plans, which I was discussing before. I'm going to give you a little history on this. This is an important thing. You have to kind of recall what I said in the beginning about Medicare, Medicaid, and so forth. Medicare Part C is a commercial insurance plan that takes your Part A benefits, hospitalization, your Part B benefits, your doctor, and if it is considered a managed care plan, a plan that delivers a network of doctors and hospitals that you have to use, it will also include your prescription drugs automatically. Why is that? Because as they move to take the Medicare system and the Medicaid system and bring them par as far as money goes, and eventually merge them into one super system, people who are on Medicaid are required by law to have managed care. They don't have a choice about it. So it's important to understand that the managed care model in Medicare Advantage is designed to absorb the Medicare, Medicaid patients because they're required by law to go into managed care. More importantly, they're forced to take whatever drug formulary is presented to them. So that plan may give you a formulary and not cover one of your drugs, and again, you have to take that drug formulary because it's part of your plan. So when you choose a Medicare Advantage plan, Part A and B, that includes prescription drugs, you're stuck with that formulary. Okay? There are generally 4 major types of Medicare Advantage plans in the marketplace. The first one is a PPO, or Preferred Provider Organization. What is a PPO? It's a network of doctors and hospitals that have contracted with the plan to deliver services and health care to the population of members who join that plan at a discount. Yes, sir?
You said they were going to be forced into Part C?
Medicaid patients.
What if they can't afford it?
Well, if you're on Medicare, Medicaid, you're what we call dual eligible. It's not a matter of affordability. It's given to them for nothing.
So they're not forced to,
They can't choose a plan that is not managed. In other words, they can't say, I don't want a managed care plan. They have to choose a managed care plan. They're given it.
I see, okay,
It's not like they have a choice. They have to take it.
okay.
So, a PPO is a preferred provider network that is a network of doctors contracting with the hospital and the plan together at a discount to deliver health services. But the way PPOs are presented is that, don't worry, we have a network of doctors and hospitals, but you can go out of the network at additional out-of-pocket costs. You just pay a little bit more out of pocket. The PPO concept was really developed in this market space to present to people the ability to go to any doctor, any hospital they want, or stay within a network and work within a discounted medical delivery system. But if the network wasn't important, why have it at all? The reason for the network is very obvious. The network provides the actuary the ability to price his plan because he's working on discounted services. If every member in a PPO goes out of the plan, that actuarial projection of lower costs goes out the window, hence the plan becomes insolvent, and eventually we have to do 2 things. Either raise premiums or shift costs to the beneficiary. And you're going to see how that works in a second. So PPOs, even though they're network plans, were promoted in the general area on Long Island as, don't worry, go wherever you want. You know, you don't have to worry about the network. But always keep in mind, if the network is not important, then why have it at all? The next type of plan you see predominantly is HMOs. HMOs are closed loops. You cannot leave the network, period. You have to use doctors in that network. And if you look at what just happened in the news there, where doctors are being dispersed out of these networks, they're restricting access to a select group of physicians who work at a discount, and you don't have a choice. You have to use them if you join an HMO. HMOs are closed loops. That's the most important thing to remember about them. The only time you go out of an HMO is when you have a life-threatening condition not treated in 24 hours, which could possibly result in death. It's that severe. If you go out of the network, you're all out of pocket. So keep that in mind. The third type, which used to be popular, was private fee-for-service plans. You'll still see them now and then. A private fee-for-service plan made this promise to its beneficiaries. See any doctor, any hospital, anywhere, at any time, anywhere in the country, as long as that physician accepted the terms and conditions for payment under the plan. What does that mean? It simply means this. The terms and conditions for payment under the plan was that the doctor had to accept a discount. If he didn't accept the discount, he didn't have to treat you. So even though private fee-for-service plans were popular when Medicare Advantage first came out, they've gone by the wayside because no doctor is willing to work for less, otherwise he'd join a network anyway. So private fee-for-service plans, you'll still find them, but very rarely. The fourth type right here is a medical savings account, an MSA. An MSA plan is a new type of plan that was enacted in law in 1997, along with all other Medicare Advantage plans. There are 2 types of Medicare Advantage plans: managed health care, which we just discussed, PPOs, HMOs, and consumer-directed health care plans, MSAs. The promise of an MSA is very obvious when you see it. I'm going to show it to you in a minute. The most important thing about Medicare Part C is to know that it doesn't cover vision, dental, and hearing. It's an additional optional benefit the plan can choose to enter or not enter into agreement with you. In other words, they can add it on or they can leave it off. It's up to the plan. It's not required under original Medicare. So, How do Medicare Part C plans make money? I'm just going to recap this real quick, which I discussed before. A Medicare Advantage plan, whether it's managed healthcare or consumer-directed healthcare, goes to Medicare and says, what is the average monthly cost of a Medicare beneficiary in the county in which they live? In New York County, right now, it's $773 a month, whether you use healthcare or not. So Medicare determines that every month, $773 is their cost consistently, whether you're using the healthcare or not. The plan, whatever Medicare Advantage plan you join, simply says, we'll accept the $773 and we'll deliver all the same rights, privileges, and benefits as original Medicare to all the beneficiaries and relieve the federal government of the liability of a Medicare beneficiary. They're paying a premium no different than your homeowners or your auto insurance to a commercial carrier to take on your risk. If that plan has a star rating, which is how Medicare determines whether the plan is good or mediocre or really great, they pay them a bonus. The 5-star plan gets $894. There are no 5-star plans. 3.5-star plan gets $879 and so forth. The average plan is going to hover between 2.5 and 3.5 stars. So this is what the average premium is that's paid by Medicare system if you join a Medicare Advantage plan to that company. That's how they make money, and that's how they sometimes can say, our plan has a 0 plan premium. The actuary took that money, determined he could discount medical services and deliver a health plan at a 0 plan premium. But if people are bailing out of the network, their costs are thrown off, that's not enough money, and they have to resort to change their plan year over year by adding costs to it, such as premiums, deductibles, and copayments. So, before we go any further, there's 3 items when I talk. I'm going to make sure that we're both on the same playing field. Premium, that's a known loss. You will pay it whether you use the plan or not. It's no different than home or auto insurance. Copayments are fixed costs for healthcare. Instead of a percentage, it's a fixed dollar amount that you can determine that's what your exposure is. And your deductible. The deductible is the amount you pay before the plan kicks in. So knowing those 3 terms is very important as we proceed through here. So, you got to add the premium, you got to add the copayments and deductibles, and what you'll ultimately end up with is your true out-of-pocket cost. This is a very important aspect of when you're determining your health plan, what's important for you. A lot of people focus right here. This is really just one piece of the overall equation. You have to focus over here as well, because a plan can lower its costs by shifting the burden to you. It's what's called cost shifting. Instead of saying it's $5 to see the doctor, it's $15. Seems minor, but it's a cost shift. And if you're a heavy utilizer, that's an additional cost that you have to account for in the calendar year. So you want to look at your true out-of-pocket costs to understand what medical insurance is going to impact your finances. There's 4 ways we do it. The first way is through Medicare supplemental insurance. This is traditional. This is what people bought since 1965. Medicare supplements are secondary insurance products. They're second to original Medicare. You stay in original Medicare Part A and B, that 80-20 scenario. You buy a supplement, you pay a premium, a known loss. You know you're going to pay it whether you use the plan or not, and that policy pays everything that Medicare does not, such as deductibles and coinsurance. In 2013, going into 2014, the total cost for the standard Plan F, which is the most common Medicare supplement, let me show you what it looks like here. This plan right here, Plan F, which covers everything that is not covered by Medicare, Part A and Part B. You have no cost other than your monthly plan premium. Costs $3,072 a year right now. So if you took a Plan F supplemental, for sure you're going to spend $3,100. You have to buy a prescription drug plan. The average cost is about $40. You have to add that in. You have your deductible for Part D. You have dental and vision, which I put in there because most people ask me, can I get that? So if you took a supplement and wrapped around original Medicare, you will spend, for sure, about $4,100 out of your income this year, guaranteed. And if you never see a doctor any day in that entire year, it still cost you $4,100. That's a cost. So, this is why people look at Medicare Advantage plans. Medicare Advantage plans are different than a supplement. The promise of a supplement is because you're an original Medicare. It's any doctor, any hospital, anywhere in the country. See anybody you want, fully covered. Medicare Advantage plans say, give up a little freedom. Use the network that we provide for you, and what we'll do is we'll reduce your cost. No longer will you pay a $3,000 premium. With this particular plan, which is the most popular PPO in Suffolk County, 3 years ago, they started with a zero plan premium. They said we have a network of doctors who work at a negotiated rate. You're going to give up the ability to see any doctor, any hospital, anywhere, but don't worry, our network you can go out of. And what happened is 3 years ago, they had a zero plan premium. Last year, they went to $38 premium. And this year, 2014, it'll be a $50 premium. So they went from 0 to 38 to 50 in 3 years. That seems kind of benign. That doesn't really make that big a hill of beans, right? You went from $0 premium on an annual basis to $600. So they've shifted some of the loss that they're sustaining because people are bailing out of the network and made it up over here. But here's the more interesting thing. They went from a $4,500 out-of-pocket maximum, co-payments, deductibles, and so forth, aggregating up. 3 years ago, it was $4,500. Now it's $8,500. They've doubled your out-of-pocket exposure. That's significant. That's a 100% increase in 2 years. What they've effectively done is they can't come to you and say, listen, I know we were zero. We need to charge $300 a month premium because we're losing money like crazy because no one's staying in the network. They're all bailing out and going wherever they want. It's throwing our actuary tables off and the costs are out of control. They can't come to you and say, give us $300 a month because what would you do? You'd buy a supplement, right? It's cheaper. What they did is they cost shifted. They said, every time you go to see a doctor, it's no longer $10, it's $20. If you go to the doctor multiple times, it's not $4,500 where we pick up at 100%, it's $8,500. They're cost shifting the burden to the beneficiary and very slowly doing it year over year over year. Eventually, this plan will just be canceled. They'll just get rid of it and say we only offer an HMO, which is exactly what's happening. The next type of plan, go back over here, is an HMO plan. This is the most popular HMO in Suffolk County. Highly restrictive. You can only use doctors in the network. Only. The only time you can bail out is when the doctors, when you have a life-threatening condition, right? So, people choose the HMO because it used to be a zero plan premium, but in the last year it went to 44, and the year after that it went to 84. So in 2014, they've gone from literally $0 to $84. It's a major increase, and they've increased the out-of-pocket maximum from $3,400 to $4,900. So again, more cost shifting. This is because the network's managed care environment is not sustainable financially for these plans. They're losing money. So instead of just coming to you and say, listen, we got to charge you this massive premium, they cost shift to you. The other aspect here that's important, you see the Part D premium? They say it's zero. It's not zero. It's part of this premium up here. So when you go onto the federal website, they say it's $84 and then they break it out. Medical is maybe 10, prescription drug is 74. So what's happening here is they're charging you a flat premium because it's managed care. They're required to include the Part D, so they say it costs you zero, but the reality is it costs you something. And it's the prescription drug that's accelerating away and causing the problems. But nonetheless, both of these types of managed healthcare plans are trending towards higher cost shifting, and eventually probably will collapse under the financial burden that they're sustaining. Here is a medical savings account. What makes this plan different than managed healthcare? An MSA, first of all, was enacted in 1997 along with all other Medicare Advantage plans. It's been around a long, long time. The advantage of an MSA over managed care is that you can see any doctor, any hospital, anywhere in the entire country as long as they're a Medicare provider. No network. Most importantly, this plan is funded by CMS on a $0 basis. There never is a premium in an MSA because the way it was designed by law does not allow for a premium. It has to be a zero plan premium by design. The way an MSA works is a very simple proposition. Unlike managed care, where the plan delivers to you a network, says you have to use them, and pay co-payments and deductibles along the way, and have an out-of-pocket maximum, an MSA simply says to you, you're an adult, you can make your own decisions, you should see any doctor, any hospital, anywhere at any time, you'll make that decision, and the federal government will fund your health care cash, and you say who, when, and where you get that health care. It looks just like this. Over here. January 1 of every calendar year, the plan provides for you a checking account called an MSA account. The federal government, CMS, deposits in that account for you, in your name, tax-free, irrevocably, $2,500 in cash. January 1, you get a checking account, there's $2,500 in there. You see any doctor, any hospital, anywhere, at any time. And when you go to see the doctor, you pay the doctor out of your checking account. So if you see Dr. Frankenstein and his Medicare approved amount for his office visit is $100, you simply take out your checking book, you write a $100 check, pay him, and you leave. You make the choice of what doctor, where you see him, when you see him. And if he says, by the way, you need an MRI, you don't have an administrator at an office in an insurance company saying, you know what, MRIs are not really important, you should just get an x-ray first. It's cheaper and it'll probably tell us the same thing anyway. You'll make that decision whether you need the MRI or not, or the CAT scan, or the angioplasty. You're in control of your own health care. This is consumer-directed health care, where the federal government gives you money up front, and after you spend the $2,500, you're only at risk for the next $1,750 out of your pocket. Once you spend combined, all Part A and B, in the calendar year, $1,750 over the $2,500 they gave you, the plan pays 100% of all your health care for the remainder of the year, unlimited benefits. That is a true financial benefit to you, because now you have the right to manage your own health care because you have the power of the purse. That's a powerful financial tool, because when you're talking about to your doctor, listen, I decide whether I see you or not whether the plan lets me see you or not. You're taking control of your health care. You ever get to call the doctor's office, say I have a sore throat, and they say, see you next Thursday? Ever happened to you? When managed care, that's because that doctor has only slotted so many people in that managed care plan for that day. After that, he doesn't want to treat anymore because he only got paid so much for them. Under an MSA, when you call up and say, Dr. Smith, I need to see you today, I have a strep throat, and they say, see you next Tuesday, you can say, no, I don't think so. I'm going to go to another doctor. I choose when, where, how, and why I get health care delivered to me, because it's consumer directed. So an MSA puts the power of your health care back in your hands without any managed component. There is no network to deal with. More importantly, this is good for your doctor. Why? Because under an MSA, there is no repricing for the services. When the doctor comes, when you see your doctor and his bill is $100, you pay him $100. You're not asking him to discount his services by 20% and work at 80 cents to the dollar. The plan is designed to pay your physician 100% of his Medicare approved amount. So for your physician, it's good, because now he can stay in business and deliver healthcare services to you and not transfer your healthcare to a medical technician that he can afford at 80 cents to the dollar. He can deliver healthcare to you directly because he's getting paid exactly what he should be paid. And more importantly, you're making the decision on whether or not he's your doctor or not. Consumer-directed healthcare is the trend, in my opinion, in healthcare because it's fully sustainable. So when we talk about an MSA, here's essentially how it works mathematically. It has a zero plan premium. You don't pay anything, not because the plan decided to offer it that way, because the law designed it that way. You can never have a premium. You don't have to worry about a premium increase. It's not going to occur. You have to have a Part D. Why? Because it's consumer-directed health care. People on Medicaid cannot get it. It's prohibited by law. So this plan, unlike managed health care, which is MAPD, detaches the Part D and enables you to go shop the market for your prescription drugs. It's a standalone MA product. It's a huge advantage. You have to buy that, so we have to account for that. We have to add dental and vision, and here's the most important thing. The maximum out of pocket, $1,750. That's the most that you would spend after you've spent the $2,500 in the account that was given to you. So your risk is limited to $1,750, half that of a supplement, a fifth of what it is under a PPO, a quarter of what it is under an HMO. Your out-of-pocket maximum is limited to a manageable amount, which converts a catastrophic financial event into a manageable amount of $145 a month if you have claims over $2,500. If you don't have claims over $2,500, you see your doctor twice a year, spent $1,000 a visit, you actually had a zero premium and a zero out-of-pocket cost because the first $2,500 is funded by the plan, right? Gets better than that. Let's say you don't spend any of your $2,500 this year. You get the money on January 1, you have a great year, never see a doctor. On January 1st of the following year, that money rolls over, you get another $2,500, and you start out year 2 with $5,000 in your account, tax-free. And on it goes. If you don't spend this money for health care because you didn't need any health care, you get to keep it. And it stays in your account, tax-free, grows at interest, tax-free. I'm going to answer your question in a second. And you can spend that money on any IRS-qualified medical expense, which includes Part A benefits, hospital, Part